Today about closure devices and angiogram access. So we're going to talk a little bit about access in general, and then we're going to talk about some devices and some methods, and after that we're going to have the hands-on station. And before the hands-on station, I'm going to also show you some videos. So we need vascular access to access our procedures. Sometimes we use larger sheaths, and thus we have more complications and bleeding, and thus the need for closure devices appear. And the more interventions that we do, the more wider calibers that we need within our devices, and thus with time we are using more and more larger devices, although and that will increase the need for closure devices. So the first step of closure is obtaining good access. Without a good access, you're doomed. And obtaining a good access to the common femoral, we can use either the landmark, anatomical landmark, with the inguinal ligament, or we can use the fluoroscopy guide or a cut down. But the gold standard is doing the ultrasound. You can visualize it. It's not time consuming. And you can differentiate between the artery and the vein. You can see the bifurcation. You can see the inguinal ligament and the branches. And you can also check the calcification of the vessel. So if you have a calcified vessel, don't use a closure device. And then from there, you set yourself up for winning or for having a complication-free procedure. So, with the access, we have complications related to bleeding, dissection, hematomas, and the closure devices will reduce morbidity. They reduces the hospital stay. We get early mobilization, and patients would really improve, and it's more comfortable compared to compression in the groin. So we have manual compression, mechanical compression, non-approximating closure devices, and we have approximating closure devices. And we have examples of all these devices here on the hands-on stations. So with the manual compression, this is the traditional approach. Usually we have patients be in bed rest for 6 to 8 hours. It has these limitations, but it's labor and time intensive. And we usually compress 3 minutes per French in arteries and 2 minutes per French in veins. So if you have a 5 French arterial access, we compress for 15 minutes. But with the venous access, we use the compression for about 10 minutes. And what we basically do is we apply the external compression. It's a manual compression. And we then have the coagulation cascade start. We usually like to wait for the ACTs to be at a lower number, and then remove the device and apply the compression in the groin. It's a low cost, it's simple, it's contradicted in larger devices, and when patients are on anticoagulation. The mechanical compression is a method. I don't like it in the groin, but it's a method that would really, make the labor less intensive, and we usually wait for the sheath to be to the ACT to be less than 180 seconds. The failure rate is about 8 to 10%, although some studies showed a success rate of 100. And with the complications, we can experience lots of hematomas and bleeding, about 8%. So we'll talk now about the passive closure devices. And with the passive closure devices, what we basically is we deploy a plug or a sealant or a gel on the site, and that site will tamponade or accelerate the clotting process, and thus we have the patient have bloodless, hematomaless, or complicationless access. And it's indicated for diagnostic and therapeutic. We usually use them for 5 and 7 French arteriotomies, and it's the contraindications are the allergies, calcified arteries, coagulopathy, and prior surgery or radiation to the groin. With the deployment in general, we confirm the position. We would like to deploy the plug and remove the delivery system. They're very simple, very easy. Takes about less than a minute to do the whole deployment. And it works just like with the manual compression, activating the coagulation cascade. And we have some sealant that would also help to activate the thrombin and the coagulation there. So some examples, we have the mix. It's basically, as you do your access here, you inflate a balloon to help within the artery, and then you apply the glycol sealant. The balloon helps have the sealant above the wall, and then you deflate the balloon, and then you can remove it. And patients can ambulate within 2 hours, and the complications are low, and it is significant. The ExoSeal device is a similar device, but without the balloon. Within the wire, you apply the device, you get the blood, and then with the you confirm your position with the indicator, and then you apply your polyglycolic acid drip plug. So the time of ambulation is better, time for hemostasis is quite less compared to manual compression. The Vascular, basically it's the same idea. You put in the plug, but to place the plug abutting the wall, you use a collapsible disc. So the disc will be intraluminal, and you apply the plug, and once it's positioned in a good position, you just pull up and collapse the disc and pull it up. And we also can have other accessories that use the same idea, with having a plug on the extra lumen and some anchor intraluminally that will be dissolvable. So the failure rate's still quite high, and I think that because it is so simple that people use it too liberally. The bleeding is less than 1%, hematomas are low, pseudoaneurysms are low, and the outcome is significant for early ambulation and reducing time to hemostasis. So now we'll talk about active closure devices before we go to our videos. So we like to achieve this hemostasis by approximating the arterial puncture. So basically you're actively bringing the wall together, and thus achieving hemostasis. So it's either a suturing mechanism or a sealing mechanism. Suturing mechanism, just like the perclose, or the sealing mechanism that we will going to show you now. It's indicated in diagnostic and interventional procedure. It's contradicted in severe disease. The deployment technique is a bit more difficult than the passive devices, but at the end it's very satisfactory. And these devices maybe have an extravascular closure or intravascular closure, depending on the method and why they do it. So with extravascular closure, it's where you use the sutures, the clips, the collagen, and with the intravascular closure, where we utilize the anchors, the plugs, the procoagulant to help tighten the arteriotomy. So with the AngioSeal here, it's used up to 1/8 French. And what we have is that we have the anchor actively pushing the collagen plug, and thus sealing the arteriotomy from the intraluminally and extraluminally. The complication rates are very low. Patients achieve hemostasis within a minute, and they have a good outcome, and they can mobilize within an hour or two. With the start-close device, this clip brings the arteriotomy together from with 6 times, and the hemostasis is achieved within a minute and a half. Patients would ambulate within 2 hours. With the perclose device, what you basically have, once you have the wire in, you bring in the device. Once the device is within the lumen, you apply the foot plate, you abut the wall, and then you deploy the sutures. So with the sutures, what they have is that they have this thread here, and you have the sutures from the outside. And once you deploy the thread, you can go and pull it out. Once you deploy the thread at the foot plate, the thread attaches to that loop. The loop then pulls it up. Thus you get your suture. And then after that, and it's already knotted. And once you get that knot, you can pull the knot, and then you can have it approximate the vessel. You can use it on larger devices, especially if you place it prior to the procedure. So if you are planning to use it, you want to use it or deploy it before getting your larger arteriotomy. So, as we all mentioned, they all reduce time to hemostasis. Patients ambulate within a couple of hours. We have device failures, infection, and ischemia, which is the complications that are associated with access with access as a whole. And we have to consider obesity, anticoagulation, the procedure complexity, and the calcifications. So we have the hands-on stations after we do the videos. So we have 3 hands-on stations, and we would show you the videos. So at least you can understand what are the devices going to be and how they're working, and then we can go to each station and rotate. Okay? Thank you. So this is the per-close device. So this is one of the suture devices. As you see,
after the index procedure, exchange the procedural sheath for an 0.38-inch or smaller guide wire. Advance the device over the wire until the guide wire exit port is at skin level.
So here we, you can access. So what happens? The footplate is here, and the tube is what is accessing what's inside the lumen. So once you have the wires, once you see the marker here, you try to pull. You're gonna pull the wire, and once the wire is pulled, then you try to push it in until that footplate area is intraluminally, and you know that by the blood coming out of the device.
Remove the guide wire, then continue advancing the device until mark is observed coming from the marker lumen. Lift the lever to open the foot and gently retract the device against the vessel wall. Stabilize the device at 45 degrees. Depress the plunger with your right thumb to deploy the needles.
So these are preloaded. The needles will come out. You can see the thread. And once you do the step 2, you're going to pull the thread and it goes around. And that's how your suture is done. That's the finicky part. That's the part where most people don't understand. Once you understand this, then it's easy to understand how it's happening. So you already have this preloaded thread, you already have these, and once you have the needles will come up and they will attach to the thread. And once you pull the step 3, once you pull the wire or the thread will loop.
Use your right thumb on the handle and with 2 fingers, gently pull the plunger back and out until the suture is taut. Then use the quick cut to cut the suture. Release any tension on the vessel wall before taking note of the depth reference marker above skin level. Lower the lever to close the foot. Retract the device until the guide wire exit port is visible above the skin line. Reintroduce the guide.
So it's very important once you, these are the threads. Once you pull the threads, it's very important not to pull them all the way, especially the thread with the white end, because once you pull that, it locks the knot that you have.
Guide wire to maintain access and pull both the suture limbs out from the proximal guide. Either the snared knot pusher or the suture trimmer can be used to advance the knot. To use the snared knot pusher, thread the long blue rail into the snare and pull through using the snare tab. Wrap the rail around your left index finger and pull taut to remove excess slack. Back out the per-close pro-style device while maintaining guide wire access. Adopt a single-handed position to continue advancing the knot over the wire. When bleeding is controlled, remove the guide wire and continue advancing the knot. Apply slow,
So the wire is kept because you want to keep access. So if you have a mal-deployment, if it's not a complete closure, especially with some larger devices like let's say 14 or 16 French, then you want to keep that. If there's still some bleeding, depending on the bleeding, you're going to decide, shall I just put manual pressure or just deploy another one?
Consistent increasing tension. Pull on the white-tipped non-rail to lock the suture knot tightly in place. Alternatively, the same knot advancement steps can be performed using the suture trimmer. Note the depth reference markers for comparison. Always adopt a single-handed position in order to apply slow, consistent increasing tension while locking the suture knot.
And this is the last step where you're gonna cut the...
Pull back the white thumb knob to open the white suture gate at the distal end of the suture trimmer. Load both suture limbs into the suture gate before releasing the white thumb knob. Pull the red lever to trim the suture limbs.